For our next session, we're going to take a closer look at environmental factors, occupational factors, and how they impact kidney health. And today we have several important guests who each have different perspectives from industry, from science, and from medicine to elaborate on this topic, which has captured the imagination of patients, medical professionals, and government officials around the world. Our next guest is Dr. Valerie Luyckx. She has university affiliations at the University of Zurich, Harvard University, and honorary affiliations at the University of Cape Town, South Africa. She's joining us as an expert on how factors in the environment and society impact kidney health around the world. She has very particular insights, and we'll ask her a few questions after she presents. Dr. Luyckx, go right ahead.
So thank you very much, Paul, and the AAKP and George Washington University for having me here to take part in this wonderful webinar series. What I've been asked to discuss today is some of my experience and my journey in understanding more about equity and justice in nephrology. So I don't have any financial disclosures, but I often like to disclose my privileges. I am very privileged to be participating in multiple working groups in the various international nephrology societies. And this has really given me a very privileged position to be able to understand more about global health and nephrology. So the overview of what I'll be discussing in about the next 20 minutes is going to be to share some of my experiences in nephrology and as a nephrologist around the globe, and to share my journey in advocating for kidney health and more equitable access to care, with a focus on dialysis as an example. So just to begin with, some clinical realizations. So I began my training in nephrology in the United States, and as I'm sure many of you know, chronic dialysis was really born in the US. Kolff developed a hemodialysis machine, which in the early 60s actually became usable as a chronic dialysis modality, was able to keep people with end-stage kidney failure alive over a prolonged period. And as you can imagine, at the beginning, resources were extremely scarce. And there was a lot of ethical challenges that arose about who should actually be accepted onto the chronic dialysis program and who would not be accepted and who would actually essentially be left to die. So nephrology is really credited almost with being the specialty where biomedical ethics and clinical ethics as we know it started. At the time, there was a God committee, so named, in Seattle, which was a group of people who were deciding essentially who would be acceptable for dialysis or not. This then provoked an outcry when it was reported on in the national press. And as we all know, since 1972, dialysis became the first and only for many, many years condition that was covered under Medicare for people irrespective of age. I then went back to South Africa, which is where I come from, as a nephrologist, and was working in a very large hospital in Soweto in South Africa. And South Africa essentially covers dialysis for eligible patients. So the country provides dialysis and covers all the costs associated with dialysis. But the key is that for a person to be eligible for this program, they need to be transplantable. So this really means they need to be well enough and not have any contraindications to be transplanted. In South Africa, there is also a committee of specialists and various other people who run through the cases once a week in some places and essentially make these decisions on who is acceptable for the dialysis program. But there are very objective criteria, largely medical and partly social. So my colleague Rafiq Musa in Stellenbosch decided to try to take an inventory of what was actually happening as outcomes of these committee discussions. And what he realized that only around 25% of people who were presented to the committee having kidney failure were actually accepted to the chronic dialysis program in the public health system in South Africa. So as you can see, this is the people in the blue, and some of the people in the orange will be accepted. And most of the people who were turned down, more than 50%, were actually turned down on socioeconomic grounds and not physical grounds, which is a reflection of the major hardship that many people are living under in South Africa, meaning that it was anticipated they were probably too poor or lived too far away to be able to follow up successfully if they did receive a kidney transplant. Importantly, in South Africa, the 16% of the population that's covered by private health insurance have access to dialysis without any question. I then also had experiences in nephrology in Canada, and I happened to be the nephrologist responsible for people who were dialyzing on this bus, which is parked next to a hospital in a small rural hospital. Canada has a national health system, and so costs of dialysis are covered. And actually, given that people have to travel very, very far distances, there was a decision made to actually bring dialysis to the people. So this was a wonderful opportunity for several patients who had previously had to travel hundreds of kilometers a day to and from dialysis in the large city. The barriers to this bus were largely weather problems, as one can imagine, in northern Canada. However, there were also some patients who still lived far away from this bus and still struggled with transport costs, having to pay out of pocket, and also the distances. In 2010, I participated in the Renal Disaster Task Force for providing acute dialysis to crush victims after the earthquake in Haiti. And there, when I came into the dialysis unit that had been taken over by Médecins Sans Frontières, I saw a notice on the wall which basically said that until further notice, dialysis would be free. So I then realized that the patients who were dialyzing in this university hospital unit were having to pay $100 a treatment and bring their supplies, which they could buy from small pharmacies around the hospital. Or for people who were dialyzing in the small private unit, they could pay $200 a treatment. So as one can imagine, given that Haiti is one of the poorest countries in the world, very, very few patients were able to pay for dialysis out of pocket. I was also asked through the International Society of Nephrology to participate in training and teaching of the nephrology curriculum for medical students in Malawi. And all of a sudden, one day, I got a phone call saying, would I be able to come, because they were deciding to start dialysis. So I was a little bit surprised. But it turned out that some machines had been donated several years before, and the government decided to provide free dialysis for everybody in Malawi. They were willing to pay for the cost of the dialysis supplies, the nurses and all, but we're not going to provide any medications, laboratory tests, catheters, etc. What was the rub here, however, was that there were about 15 machines in the public system for a population of 8 million people. So the clinicians here were really struggling on a daily basis, having to choose amongst multiple patients with end-stage kidney disease or acute kidney injury on the ward who would actually get the available dialysis slots on that day. There was, again, a very small dialysis unit where patients could pay $200 out of pocket, but this was mainly for expats. And then most recently, an experience that I've had involved with the European Renal Association and International Society of Nephrology has been in trying to support dialysis services on the ground in the countries which are undergoing the 3 current armed conflicts. So we're not able to do any on-the-ground assistance, but we have been really trying to mobilize support in terms of money, in terms of supplies for medications and dialysis supplies. So as you can see on the top row, there were approximately the same amount of hemodialysis patients in both Ukraine and Sudan. There were fewer in Gaza, but Gaza is obviously a lot smaller. And Sudan, in fact, had the most number of patients who were living with kidney transplants. In both Ukraine and Sudan, dialysis had been provided for many years prior to this conflict by the state under universal health coverage. And in Gaza, dialysis was being relatively sustainably supported by continuous donation from international organizations. But when we look at how the world actually responded to these crises, for Ukraine, there was very rapid procurement. Lots of organizations stepped forward and donated money, donated supplies, and we were able, after about 2 to 3 months, to stabilize really the supply chain for dialysis supplies in Ukraine, and dialysis was able to continue. In Sudan, however, despite many, many entreaties, donations were extremely slow of money or supplies, extremely slow procurement to get supplies into the country. And there were actually weeks where there were no dialysis supplies at all in the country, and patients died, and there were newspaper reports of dead dialysis patients lying in the street. In terms of Gaza, there were a lot of offers for donations. However, because of the problems at the border, the deliveries of donations have been extremely slow. So in describing all these examples that I have lived through in the last 10 or 15 years, I've really come to this realization that there is an enormous amount of inequity in terms of access to dialysis. And the question is, do we just accept this as a fact of life, or is there something we can do about this? So I like to show this infographic because I think it explains extremely well the difference between justice and equity and equality. So if we think about an equal system and we look on the left-hand side, we can see that each of the 3 spectators has received the same box from the system in order to try to look over this fence. But as we can very clearly see, the same box doesn't help each person equally. So if we think about equity, this is more a focus rather than on giving equal resources. We want to create equal opportunities. And here we can see that it's necessary sometimes to redistribute these boxes potentially differently to different people to meet their needs, all to have the same opportunity to look over this fence. In reality, however, and this became extremely clear in COVID, some people have way more boxes than they actually need. Some people do have just enough, and there are others who start even more far behind and need even more assistance to look over this fence. And here I would say the dialysis patients, especially in settings of crises or pandemics, become really the most vulnerable and are often left behind. So this has brought me to a lot of what I've proceeded to do in terms of research and my academic questions. So I began my fellowship in the laboratory of Professor Barry Brenner at the Brigham in Boston. And here we started working on this idea that Professor Brenner had proposed in the late 80s, that it's possible that children who are born either with low birth weights or preterm, and this often happens in people of disadvantaged or minoritized populations, may be born with smaller kidneys. These kidneys would have fewer nephrons. This might predispose them to sodium retention and hypertension later in life. And if they have additional stresses on their kidney and additional kidney injury, they would lose more nephrons and reach a critically low number of nephrons more rapidly than someone who had been born with a normal nephron number. And this could explain what we do observe, that chronic kidney disease and hypertension tend to be more prevalent in disadvantaged populations where both low birth weight and preterm birth are both frequent. So in order trying to think about this and realizing that there are these fetal origins of risk of chronic kidney disease, I started to ask myself, together with colleagues, what could we possibly do? How does one reduce preterm birth or reduce low birth weight? And so this really brought us to this idea that we need to have a healthy mother. A healthy mother needs to have been a healthy girl so that she grew up with a healthy body. She obviously must have had access to good nutrition, lived in a safe house, lived in a safe environment, had been able to go to school, etc. So for a healthy baby, we need a healthy mother, and she needs to have lived in a healthy society. So this brought us really to this realization and coincided with the launch of the Sustainable Development Goals in 2015 by the United Nations, that we really need a lot more than just focus on health in order to have healthy people living on a healthy planet, which is really the ultimate goal of the Sustainable Development Goals. So as we can see here, there are 17 goals, but only one is focused on health. But interestingly, each one of these 17 goals has an impact on either risk for kidney disease or can impact a person's ability to gain care if they have kidney disease. And in turn, the health goal feeds into supporting all the other goals, because healthy people are more economically productive, take more care of the environment, etc. So this concept really just shows that looking after kidney health, one needs an equitable society and a society that's caring about the planet. So this brings us to the question of, if we want to try to achieve equity in terms of access to kidney care, and especially again, if we think about the dialysis example, which is the tip of the iceberg, many people say quite glibly that we need universal health coverage, but what actually mean? So this is a cube that was launched by the WHO, which really explains that if you look at a given country, their health budget is the blue box, but the entire health needs of the population is the white box. In many high-income settings, the blue box is essentially as big as the white box, meaning that all healthcare needs of the population are covered. But in many low-resource settings, the blue box remains quite small relative to the white box, and politicians and decision-makers need to try to understand what healthcare needs are we going to fulfill and include in the blue box, and what gets left outside, meaning patients have to fend for themselves. And unfortunately, dialysis and kidney care are very much often left outside in the white box. So this is just an example of the massive inequity that's relating to end-stage kidney disease and access to renal replacement therapy. These data come from 2010. If you look in the left column, at that time, there were 2.6 million people around the world thought to be on dialysis. Now we think it's around 4 million. But what's more important is the right-hand column, where we can see that the country distribution of people who have access to kidney replacement therapy really shows that pretty much everybody who's receiving these therapies lives in high or upper middle income settings. There's only a tiny amount of people living in low and low middle income settings, despite the fact that the incidence of chronic kidney disease is actually very, very similar across the world. And so if people have the same incidence of chronic kidney disease and the same possibly risk of kidney failure, it really doesn't make sense that so few people in low income settings have access to kidney replacement therapy. And what we do know as well from this paper is that they estimated that 2 to 7 million people around the world die mostly in low income settings without access to dialysis. So with colleagues in South Africa, we did a systematic review to try to identify what's actually going on, where are the potential barriers, and we identified that there are 5 quite large delays that probably lead to the fact that people don't have access. The first important delay is that there's often a delay in diagnosis. Communities and community health workers in lower resource settings are not aware of kidney disease, and patients don't have universal health coverage for kidney care and have very low access to primary care and so often are not diagnosed. So when someone is actually diagnosed in these types of settings, it means that they've actually become symptomatic. But before they get to a diagnosis, the symptomatic person is at home, and their family, who likely has very limited resources, actually needs to either start searching for resources to get somebody to a hospital, or they decide, is this person important enough in the family to actually spend precious resources on? In many poorer settings, people actually seek help from traditional healers, and it's very unlikely there that they will have a diagnosis of kidney disease. So if the diagnosis is missed, many people will actually die. Some people, however, will find their way back into the healthcare system or may have gone in there directly. And in small settings, in some places, kidney disease may be diagnosed. But very often in these low resource settings, dialysis is only available in the large centers, in large cities, and very often requires referral. So this often leads to delays. And so often by the time a patient gets to a referral center, they are either too sick or there may not be actually resources available at the center. Although machines might be full, there may not be staff, there may not be electricity, water, or supplies, or the required out-of-pocket costs are too high. The patient doesn't receive dialysis and unfortunately still dies. The minority of patients in these settings receive dialysis and survive. So we try to understand as well, what do the clinicians actually experience in these environments? Because it's quite depressing when they realize that many patients with kidney failure are not able to be taken care of properly, especially since they know what's happening in the high income settings. And indeed, in the survey of 40 senior nephrologists in sub-Saharan Africa, we asked about experiences always, often, or sometimes in the blue. And we can see on the left-hand side that around 90% stated that they often have to make difficult choices based on limitation of resources. And very significantly, on the right-hand column, around 40% of these senior clinicians have had to restrict dialysis for one patient to give dialysis to another. And so this leads to a lot of moral distress and is actually leading to people wanting to leave the profession or leave their country. So this brings us again now to this idea that we need to very urgently include dialysis in universal health coverage because people are not able to afford and doctors are not able to provide the care that they want to and should be providing. If we think about universal health coverage, we have to answer various questions. Is dialysis, for example, a priority need? I think we've discussed that the numbers are very high. We know that there are effective interventions like dialysis. We know that people needing dialysis are worse off because without dialysis, they die relatively imminently. And we also know that dialysis is definitely unaffordable over a long term for an individual. And so people needing dialysis require financial risk protection. These 3 criteria are all criteria that are usually used to get interventions into the blue box. What we also need to think about on dialysis, however, is the idea that we provide a quality service. So patients need to get enough dialysis. One can't compromise by dialyzing once a week or with suboptimal catheters, etc. So given the enormous costs associated with dialysis and the large number of people that require it, unfortunately, if dialysis was included in the blue box in many low-income settings, this would drain an enormous proportion of the healthcare budget. So this is a big conundrum in nephrology. And here is an example, and it was estimated that if every patient in Kenya who required dialysis received this might require between 8 and 15% of total government health expenditure. So one needs to ask oneself, if 15% of health expenditure is going to dialysis, what other health needs of other people are not being met? So this is a major conundrum, and one of the problems with dialysis is that it's so expensive. The WHO has now been raising this issue of fair pricing and fair profits relating to many other health interventions, including as the discussions proceeded for the vaccines during COVID. And I think we need to start discussing and bring in the dialysis industry to find ways that we can potentially reduce prices to improve access. So until recently, I have been focusing largely on adult nephrology, but having moved now to Switzerland, I've been exposed to some new awakenings. I've been learning about the field of kidney disease in children and realizing that this is really not only complex in terms of knowledge, but also enormously complex in terms of the logistics of managing children and the impact on their families. We know that children tend to have more rare kidney diseases than adults, but unfortunately, especially in low-income settings, the access to the often expensive medications is not there. And what I've also come to realize is that medications that we take for granted for use in adults have often not been studied in children. And so this is another important inequity that we need to think about, is how to get children early included into studies so they can benefit as soon as possible from useful medications. So just in summary, around 3.6 million people died of kidney disease in 2021 from the Global Burden of Disease study. This means that 7 people per minute around the world died of kidney disease. And indeed, kidney disease is the 8th leading risk factor for death. So kidney disease is a big problem, but thus far has been underappreciated, and there are many people dying without access to care. We know that many public health strategies can actually support prevention of chronic kidney disease, and so these are extremely important. We need to continue to advocate for these. World Kidney Day this year was also advocating strongly for equitable access to care and optimal medication so that everyone everywhere can benefit from the latest new developments in medication for chronic kidney disease that are saving lives. And finally, I think we need to remember not to forget the individual when we're thinking about these global inequities. And kidney disease can be quite unforgiving. This is a photo of the pillbox of one of my young patients. She developed chronic kidney disease at age 2 after an episode of hemolytic uremic syndrome, got a kidney at age 4, and at age 15 has a GFR of 20, is looking at a new kidney. And we can just see for this 15-year-old how many medications she needs to take per week. And one day I was a little bit late getting into the clinic room, and she was playing with these beads on her table. And then she showed me this list. And each one of these beads actually represents that the child has had 50 blood tests or 5 catheters or has had 3 kidney biopsies, etc. So this really illustrated for me very, very clearly what a 15-year-old has already had to live through because of her kidney disease. This was a documentary that was done by a good friend while I was still working in Canada. And I really find that her documentation of the lives of these people living on dialysis is extremely moving. And for me as a nephrologist, it's been an extremely humbling privilege to accompany these kidney warriors on their journeys every day. And finally, the joy of transplantation. This was a card sent to my husband by one of his patients who, after transplant, was grateful to be able to write again in the snow. So thank you very much for listening. And these are just many of the people that I've had the wonderful opportunity to work with and the associations that have given me so many privileges. Thank you for listening.
Dr. Luyckx, I was wondering if you could elaborate for our listeners on some of the common environmental factors or toxins that are out there that impact kidney health and your insights on those.
Okay, thank you. This is an interesting question. I think there are many environmental toxins, but the one that seems at the moment to have gained really most prominence is air pollution. This is something that seems to be impacting kidney disease risk everywhere. It is contributing to a large proportion of chronic kidney disease. There was a wonderful study by Professor Ziad Al-Ali a couple of years ago that really showed that in certain segments of the United States, for example, people living in areas with the highest exposure to particulate matter had higher risk of chronic kidney disease progression, end-stage kidney disease, and also a transplant graft failure. So to me, this seems to be the major threat. And just looking at various review articles, it appears that a lot of the injury is actually related to inflammation. We breathe in the pollution in our lungs, it goes into our blood system, and it impacts on our vasculature, our cardiac function, causes inflammation in endothelial cells, and very likely also causes development of reactive oxygen species and various other injurious molecules that then need also to be filtered through the kidney and thereby cause kidney injury, probably both from a vascular and a tubular interstitial perspective.
Dr. Luyckx, I was curious, there are a lot of different discussions and perspectives on environmental issues and other things like that that may impact kidney health. I was wondering, how do you work collaboratively with folks with different perspectives so that the focus stays on improving kidney health in people and not in some of the other issues that might be more controversial or debatable?
So that's a tough one because I think, as we know, there's very inequitable, actually, generation, for example, of greenhouse gases, which are a major driver of climate change at the moment. And most of the greenhouse gases are actually produced in the global north, in the industrialized countries. And if you look at per country, it's largely US and China, for example. And yet most of the brunt is actually been felt in the global south. So, for example, in Africa and other places which are relatively low resource. So this is a big inequity, and there's been a lot of debate. Does the global north, the people who are generating all these emissions, actually owe something to the people and the countries that are trying to deal with the consequences and don't have the resources? So I think on a political level, we need to definitely all work together towards combating climate change, because unfortunately it's affecting all of us. One of the challenges is going to be, as we strengthen health systems in low and middle income settings and bring, for example, electricity to small clinics that haven't had it yet, etc., these small clinics are going to start themselves generating some healthcare emissions. So I think we need to be very clever and innovative in terms of trying to build, if we're setting up new clinics in new places or developing new therapies, we need to be innovative that these are actually as green as possible so that we can reduce the carbon footprint of healthcare itself. In terms of actually the impact on individuals and advocating for individual access to care, again, I would say that I've shown the enormous inequity in access to dialysis, for example, and a big reason for that is that the dialysis is just not affordable in many low and middle income settings. And so if we really want to think about equity, maybe if we can somehow find a way to save money through greener nephrology, using less energy, etc., in one part of the world, maybe we need to be able to somehow transfer some of those resources to other parts of the world and make things more affordable. I think we also need a huge amount of innovation in dialysis in terms of making dialysis itself more affordable, because even the very high income countries are struggling to pay all these enormous bills. So I think it's very hard to separate the individual and the political level when we're talking about trying to improve health through improving climate change.
Dr. Luyckx, AAKP has always been a strong defender of the principle of patient care choice. And I was wondering, based on your research and what you see in terms of potential issues that impact kidney health around the world, are you more optimistic today than you might have been 10 years ago about what prevention strategies and what treatments may be available to help mitigate some of these issues that you've been talking about and others have been talking about?
I think the answer to that is a resounding yes. Over the last couple of years, we've had definitive trials on multiple new medications that have really shown an improvement in reduction of progression of chronic kidney disease, reduction in mortality from kidney failure, reduction in cardiovascular morbidity, reduction of cardiovascular deaths. And these are all extremely important outcomes for any person living with kidney disease. So we now have a menu of medications, not only for people living with diabetes, but also for people with non-diabetic kidney disease. And it's just critical now that we find ways that these medications are accessible equitably and affordably to everybody everywhere. And I would argue that it is more urgent even to make sure that these medications are accessible and affordable to people living in lower resource settings, because they do not have the backup of dialysis or kidney transplant if they don't have access to these medications and they lose their kidney function. So I am extremely hopeful, but I still am a bit concerned that we have inequitable distribution of these wonderful medications at the moment, and this is something that needs to change.
Thank you very much, Dr. Luyckx, for joining us from Switzerland, and we look forward to your participation again in the Global Summit.